Good evening, ladies and gentlemen, and thank you for joining us on this Wednesday evening, and welcome to the third session of the Genetics 360 educational webinar series hosted by AMPAS Laboratories. We request all attendees to please keep their microphones and cameras off. Should you have any questions, please make use of the chat section, where you could either publicly or privately send a question to one of the presenters. Please also remember that we will run a poll after the presentation and all the answers will be provided by each presenter. I will now hand over to Sarah Walters, a genetic counselor at AMPAS, who will introduce our topic and speaker for the session. Thank you, Sarah.
Thanks, January. So welcome everyone, the third session of our 4-session 360 series. And this afternoon's presentations are going to be around adult genetics, more adult-related conditions, and we're very lucky to have Dr. Janina Lunt speak to us about hematological genetics. And then we're going to touch on one of the more common conditions of adulthood, namely hypercholesterolemia. And then we're going to talk about pharmacogenomics and its uses and how it can help us in terms of medication and treatment going forward. So thank you, Janri. Or Dr. Janine, let's start with you.
Okay, great. Let me just share my screen. Right, can everybody see that? Sarah,
Perfect.
Just give me a call.
Yeah, that's great. Thank you.
All right, good evening, everyone, and thank you for attending this third session of our AMPAS Genetics webinar series. We are really delighted to see the number of you that are attending these talks, and we hope that the information we've been sharing so far has been useful to you in your daily practice. So I am Dr. Janina Lunt, and I am a hematopathologist at AMPAS Genetics Department. So the world of hematology genetics certainly is an exciting one to be a part of at the moment. And in fact, it's now gotten to the stage where it's quite difficult to keep up with all the advances being made with genetic testing in hematology, especially for us as pathologists, where in the past, hematological diagnosis might have relied on a microscopic examination of a blood or a bone marrow smear. In many hematological disorders, diagnosis now relies much more heavily or even exclusively on confirmatory genetic testing. And a big reason why genetic testing has become so important in hematology and in clinical practice in general is the drive for the implementation of a concept known as precision medicine or precision hematology, which I'm sure is a phrase most of you are already familiar with. So genetic testing enables us to identify specific genetic characteristics of a patient, or in the case of cancer, the genetic characteristics of a tumor, which then allows the treating clinician to choose the most effective targeted treatment at the appropriate dose for that specific patient. And it allows us to predict the course of the disorder or the cancer, so we know when the optimal time will be to introduce treatment and to monitor the effectiveness of the treatment once it's been introduced. In many hematological cancers, targeted therapies are now used without the need for any chemo or radiotherapy, and the improvement in patient outcomes have been considerable in these disorders. A notable example being that of chronic myeloid leukemia and the tyrosine kinase inhibitors like Gleevec. So we celebrated World Thrombosis Day last week, for those of you who don't know. And so for my short talk tonight, I decided to cover some of the genetic testing that's available or that might be useful when investigating or treating patients with thrombosis or patients at risk of thrombosis. So I'll be discussing the inherited thrombophilia, more specifically the factor V Leiden and prothrombin variants. And then I'll also touch on warfarin sensitivity testing and the JAK2 V617F variant. And I promise Sarah that I will do all of this in 20 minutes. So thrombophilia refers to an increased likelihood or tendency to develop blood clots or thrombosis. And thrombophilia can be either inherited or acquired. But in practice, thrombophilia is typically multifactorial with multiple individual risk factors potentiating each other, often in a more than additive fashion. So genetic testing plays an important role in identifying the inherited risk factors for thromboembolic disease, specifically for the factor V laden and prothrombin variants. So how do these variants lead to thrombophilia? Normal physiological hemostasis is a balancing act between procoagulant factors and naturally occurring anticoagulants. So factor V and prothrombin, or factor II as it's also called, are important procoagulant factors and components of the common pathway of coagulation. Protein C, protein S, and antithrombin, on the other hand, are naturally occurring anticoagulants, which are necessary to stop clot formation once bleeding has been contained. Activated protein C inhibits factor V and factor VIII by cleaving these proteins, and it does so with the help of its cofactor, protein S, in the presence of the thrombin thrombomodulin complex. So thrombosis occurs when any of these anticoagulant factors are reduced, or when any of the procoagulant factors are abnormally increased. So in factor V laden, the abnormal factor V protein is resistant to this deactivation by protein C and S complex. And this is caused by a G to A nucleotide change at position 1691 of the factor V gene on chromosome 1. So this is a missense mutation, which means that it results in a change in amino acid from an arginine to a glutamine, and this occurs at position 506 of the factor V protein, which incidentally is where the activated protein C is supposed to cut. So you'll see the factor V laden variant referred to in any of these different ways, or using the RS number, which is an international reference number for SNPs. So factor V laden is by far the most common inherited form of activated protein C resistance. But just to note that there are rare examples of other factor V variants which cause APC resistance, but which will not be detected by the factor V laden PCR. And this is perhaps one reason why there's still a place for the activated protein C resistance assay. So the prothrombin variant is a result of a guanine to adenine change occurring at position 20210 of the prothrombin gene. And this lies within a non-coding region of the gene, which results in overexpression of the prothrombin mRNA. And this leads to a 30% increase in plasma prothrombin levels in heterozygotes and 70% increase in homozygotes. But the prothrombin protein that's being produced is normal, it's just at excessive levels. And then the inherited anticoagulant deficiencies are much less common, and whereas factor V laden and prothrombin variants are known single point mutations, mutations affecting the protein C, protein S, and antithrombin genes are numerous, making genetic testing a more complex and expensive process. And genetic testing is not routinely performed. So in general, the diagnosis of these deficiencies relies on functional coagulation assays, but to note that genetic testing can be arranged in cases where confirmatory testing is required. So the PCR tests for factor V laden and prothrombin variants are by far the most common requested genetic tests at AMPATH and probably in general. Between 2 to 5% of people of Northern European origin are heterozygotes for either the factor V laden or prothrombin variant. Heterozygote meaning they have one normal and one variant allele. So it's really quite common in Caucasians. So common, in fact, that the factor V laden allele was actually inadvertently included in the previous version of the reference human genome, but this was rectified in the latest version. And the theory for why the factor V laden allele is so common is that these individuals have been selected as a result of reduced postpartum bleeding. Prevalence in Africans is much lower, estimated at around 0.5%. And about 1 in 1,000 people are compound heterozygotes, meaning they have both factor V laden and prothrombin variants. And then homozygotes are quite rare, but we do see them from time to time. So what does this mean for the patient in terms of risk? So asymptomatic heterozygotes of factor V laden have a 2 to 8 times increased relative risk for a first episode of VTE. and prothrombin heterozygotes around 2 to 6 times. So the presence of a positive family history increases this risk significantly, especially if multiple family members have been affected. And the risk in factor V laden homozygotes and compound heterozygotes are also significantly higher. For some context, I've also included the increase in relative risk for some of the acquired risk factors. But you cannot interpret relative risk without appreciating absolute risk. The estimated annual incidence of VTE in the normal general population under 40 is 1 per 1,000 adults, which is 0.001% per year. So in an asymptomatic factor V laden heterozygote under 40 with a relative risk of 8 to 1, this translates into an absolute risk of 0.008% per year. So in absolute terms, the risk is still quite low. And when explaining risks to patients, it's always important to clarify the concepts of absolute versus relative risk to avoid unnecessary anxiety and potential unnecessary and harmful prophylaxis. So having an inherited thrombophilia does not mean that you will develop a blood clot. In fact, more than 90% of factor V laden heterozygotes will never develop a VTE, but to remember that multiple risk factors potentiate each other. So when counseling patients, it's important to address coexisting modifiable risk factors like obesity or immobility, and also consider alternatives for oral contraceptives and estrogen-containing hormone replacements in female patients. So who and when to test? This is quite a contentious issue, and recommendations vary widely between different professional organizations. The American College of Medical Genetics advocates for testing in patients with VTE when the results will influence treatment and clinical management decisions, and also in patients and certain asymptomatic relatives to reduce the risk of a provoked VTE through counseling about preventative measures in circumstances of elevated risk. So specific recommendations include a first unprovoked VTE in patients under 50, VTE at unusual sites such as the hepatic portal venous system, recurrent VTE, personal history of VTE with more than one family member with the history of VTE, or one first-degree relative with VTE at a young age, and then also in patients with low activated protein C resistance activity. And in other situations to consider testing are also listed. I'll share the link to this publication in the chat after my talk for those that are interested. Routine testing is not generally recommended for patients with arterial thrombotic disorders due to a lack of evidence of the association between inherited thrombophilia and arterial ischemic events. So this is just an example of what the factor V laden and prothrombin PCR results will look like. In this case, the patient is a heterozygote for the factor V laden mutation. And then the comment goes on to explain what that means. So the patient has one normal copy and one variant copy of the factor V gene. And then it also highlights what the increase in relative risk would be. But to note that this is for a first episode VTE and not for recurrent VTE. Right, so the standard treatment for VTE is oral anticoagulation, and still the most widely prescribed drug used for this indication is warfarin, which is a vitamin K antagonist. One of the many drawbacks of warfarin, however, is its unpredictable pharmacokinetic and pharmacodynamic responses. So I mentioned precision hematology in my intro tonight, and warfarin sensitivity testing would be an example of this process, where we can use the genetic makeup of a patient, in this case, specifically looking for VCORC1 and cytochrome 2C9 variants, to predict whether a patient might require lower doses of warfarin to achieve therapeutic anticoagulation, and also to identify those patients who might be at risk or higher risk of bleeding. So VCORC1 encodes for an enzyme that's involved in vitamin K recycling, and cytochrome 2C9 is an enzyme responsible for metabolism of warfarin. And these variants are very common, especially the VCORC1 variant, which is present in just under 40% of people globally, and even more so in Asians and Europeans. So the FDA now recommends pharmacogenomic testing in patients who are prescribed warfarin to optimize drug efficacy and to reduce adverse drug reactions. And more dosing algorithms are now available which incorporate this genetic information. So Sarah will be talking a bit more about pharmacogenomic testing after my talk. But since we've been talking about thrombosis, I wanted to just mention the fact that this testing is available as part of our ANPATH pharmacogenomics panel. And also to note that both factor V laden and the prothrombin variants are also included in our pharmacogenomics panel, which makes it a really cost-effective way to test for both inherited thrombophilia and warfarin sensitivity in one assay. And so in this example, the patient had 2 normal alleles for the cytochrome 2C9 gene. They were negative for both the prothrombin and factor V laden variants, but they were confirmed to have a VCORC1 variant associated with increased warfarin sensitivity. And so they should be put on a lower starting dose and counseled about the risk of bleeding complications, or perhaps considered for an alternative oral anticoagulant, like one of the DOACs. So whereas inherited thrombophilia and the warfarin sensitivity alleles are examples of inherited or germline variants, the JAK2 V617F variant is an example of a somatic or acquired variant, meaning it occurs within a hematopoietic stem cell after birth. And the JAK2 variant is a very well-known driver mutation in the classical myeloproliferative neoplasms like polycythemia vera, where it's seen in more than 95% of cases. So the reason I've included this in tonight's talk is to emphasize that the classical MPNs like polycythemia vera can present with VTE as an early manifestation of the disease, even before any hematological features of disease are present, and especially in unusual sites such as the splanchnic venous system, which includes the portal vein, mesenteric vein, and hepatic veins. And hepatic vein thrombosis is also called Budd-Chiari syndrome. So thrombosis in any of these sites should always raise suspicion for an underlying latent myeloproliferative neoplasm. And the JAK2 V617F mutation is detected in as many as 60% of patients with splanchnic vein thromboses. The mechanism for hypercoagulability in the MPNs are well described, and some of them are illustrated here. Basically an increased production of abnormal myeloid blood cells, which includes platelets, neutrophils, and red cells, increases blood viscosity, and this combined with a relatively low blood flow velocity of the splanchnic venous system and the prolonged interactions between blood and sinusoidal endothelial cells is one theory for why the splanchnic system is so commonly affected. And so again, lastly, this is what the JAK2 PCR results will look like in a positive case. So we indicate either a positive or negative result at the top. And then in addition, we also provide a quantification of the allele burden as a percentage. And this is basically a ratio of the mutant allele to the total allele. And an allele burden of more than 50% is associated with an especially high thrombotic risk in these patients. And in such cases, prophylactic anticoagulation should be considered. And so that was just a quick whirlwind tour through genetic testing in thrombosis. If you ever need assistance with the workup of a patient or the interpretation of a result, these are my contact details. And also, if there are any of the topics discussed tonight or other hematology genetics topics you would want to know more about, please post your suggestions in the chat box. And then that's all from me. And over to Sarah for some interesting info on pharmacogenomics and familial hypercholesterolemia.
Thanks, Dr. Janine. Janri, can you put the presentation up? Perfect, thank you. So in having a look at, if you remember the flow diagram from our first talk, we initially started off with NIPT and the genetics of newborns and pregnancy and pregnancy planning. We moved on last week to pediatric genetics, and I thought maybe we'd touch on one of the more common genetic conditions of adulthood, which is the hypercholesterolemia. So if we think about hypercholesterolemia, it's actually really common, affecting between 1 in 200 and 1 in 250 people worldwide. So when we're talking about familial hypercholesterolemia, we're talking about having a faulty gene, one faulty gene, therefore being heterozygous, that actually causes this hypercholesterolemia. However, sometimes we can get what we call the homozygous form, where someone has inherited 2 faulty copies of a particular gene that then causes the hypercholesterolemia. What happens, especially in these cases, is that it's a much more severe form of hypercholesterolemia, and it's usually identifiable in adulthood. As I mentioned, there's autosomal dominant inheritance, and there's a gene dosage effect where the homozygous form, you will get a much more severe and earlier onset of the condition. In our country, or in fact worldwide, there are certain population groups where hypercholesterolemia is more common. The first one is in the Afrikaner population in South Africa, and I think that this has been well worked up quite a long time ago, just in knowing that hypercholesterolemia is common in certain families. The Lebanese and the Tunisians are 2 other common population groups, and I think that I've got some information about some other groups as well. So when we're having a look at the autosomal dominant form, in a heterozygous form, we just need to have 1 faulty gene in order to have the condition itself. And so we know that for someone who is affected with hypercholesterolemia and has got 1 faulty gene, each child of theirs is at a 50% risk of inheriting that same faulty gene. The problem with hypercholesterolemia, though, is that it is often goes underdiagnosed and undertreated for the severity of the condition. And so we feel that it's really important to identify hypercholesterolemia as early as possible, because early treatment leads to the reduction in cardiovascular events and even death. So screening guidelines where there's a positive family history of hypercholesterolemia include already screening by the age of 20. However, if there's a family history of cardiovascular disease and or elevated cholesterol, sometimes screening is recommended to start from the age of about 9 to 11 years, and in some cases even from the age of 2. So there are recommended screening guidelines for dyslipidemias from the National Heart, Lung and Blood Institute in America. And I think it's worth it to ask those questions on the family history of who has had cholesterol testing, who has had cardiovascular events. There are 3 diagnostic tools that can be used for hypercholesterolemia. The US PEDMED, which includes looking at total cholesterol levels in the family history. The Dutch Lipid Clinical Network, which includes the family and the personal history, clinical examination, genetic results, and the LDL results. And that by adding all of these together, you come up with a score that puts someone in either a lower or a higher risk category. And then I think that the Simon Broom Register diagnostic criteria is possibly the one that you may be most familiar with, where either the total cholesterol or the LDL levels are measured. There's a family history of hypercholesterolemia, and then the genetic testing result is used to diagnose. So some of the common signs of hypercholesterolemia, which may not always be so obvious, includes presence of the tendon xanthomas and arcus corneae in people under the age of 45, or tuberous xanthomas and xanthelasma in people under the age of 25. And I must say that when I saw these pictures, I immediately went to the mirror to go and have a look about 4 lumps and bumps around the eyelid, and to have a look at my knuckles to see if there was any signs or symptoms of any cholesterol buildup. So some of the genetic causes include a decreased LDL receptor function. Now, LDL receptor is just one of the proteins caused by one of the genes that can cause hypercholesterolemia. And there are different classes of variation in which the LDL receptor is not working properly. Either it can be not synthesized, or it's not transported properly, or it doesn't bind on the cell surface, or it doesn't cluster where it is supposed to, or it is not recycled back to the cell surface. So the majority of incidences of familial hypercholesterolemia are actually caused by faults in the LDLR gene. If we have a look at the cholesterol pathway, and this is where I wish that we had a pointer, if you can follow, starting in the hepatocyte, the blue dot, that is the VLDL, what happens is the cholesterol is secreted from the liver to the peripheral tissues in triglyceride-rich lipoproteins, which are called very low density lipoproteins. Once they're in the bloodstream, these VLDL are transformed into cholesterol-rich LDL particles by interaction with different proteins as LPL or exchange of lipids and apolipoproteins with high density lipoprotein LDL particles that are taken up by peripheral tissues through the LDLR. So I don't know if you followed all of that in the pathway that goes across from the hepatocyte to the peripheral tissue. From here, excess cholesterol from the peripheral tissues is packaged into HDL lipoproteins for clearance. First, the free cholesterol is transferred to lipid-poor pre-beta HDL through the ABCA1. And then secondly, the first cholesterol loading changes HDL conformation and allows its interaction with the ATP binding cassette and the transporters that, along with the lecithin cholesterol acyl transferase, produce mature HDL particles that are transported back to the liver for their clearance. So a nice circular pathway between the hepatocyte into the bloodstream, peripheral tissue, and then back through to hepatocyte for clearance. So the common genes that we look at when we're looking at a case of familial hypercholesterolemia include the LDLR receptor, the ApoB, or also known as the familial defective ApoB, and PCSK9, who, when there's a change within or a variant within that gene, actually cause a gain of function. The other gene that we could look at is LDL receptor adapter protein. However, there are very few cases of this particular gene, less than 1%, that would cause the familial hypercholesterolemia. And if we have a look at those genes, the LDLR, the ApoB, and the PCSK9 are all inherited in what we call an autosomal dominant manner, whereas the LDLR-AP1 is inherited in an autosomal recessive fashion. So how common are these gene changes? So the LDLR accounts for between 80 and 85% of all familial hypercholesterolemia. And having a look at ClinVar and other databases, there are over 3,000 pathogenic variants that have been described within this gene. If we had to have a look at ApoB, between 5 and 10% of cases of familial hypercholesterolemia are caused by this gene, and the PCSK9 gene only accounts for around 2%. In our South African context, we have a lack of data just in general. So there was a 2018 review that had a look at all our populations in South Africa, and they found that there were founder mutations in the Afrikaner, the Ashkenazi, and the Indian population groups. There was only preliminary data for the Black African, for any changes in the Black African population. And it's possibly because of lack of patients who are identified, and as I stated at the beginning, are maybe underdiagnosed. So having a look at the paper produced by Prof. Derek Rahl in 2020, and in collaboration with one of the VIX units, looking at the genetics of familial hypercholesterolemia, they came up with a flow diagram of how testing for familial hypercholesterolemia should be done. Starting off with the subject with a suspected case, and then either having a family history or a first-degree relative with an LDL over 4.9, or having clinical markers of familial hypercholesterolemia, as I showed you in the pictures just now. So once you start off with that, you either classify them into either a positive or a negative. The positive, looking at whether therapy is required or not, and ending up with doing what is called next generation sequencing for all of the genes that are known to cause familial hypercholesterolemia. However, if the patients are negative and they have higher or sort of moderate LDL levels, hypercholesterolemia genetic testing is still recommended. Only when there is a much lower LDL level is the genetic testing not recommended. So basically, Prof. Rahl and his colleagues are recommending genetic testing for the majority of the population to know and understand whether there should be more rigorous screening, more regular screening, and earlier treatment for lipid to lower the lipid levels. So here is a case study that I've been involved with recently, where there were two boys of Indian ancestry, and both of these boys were below the age of 10 years. And because of the family history, their cholesterol levels had already been tested, and both of them had been diagnosed with hypercholesterolemia. Looking at the family history, they had a father who had a quadruple bypass at the age of 25, coronary stents at 35, and who unfortunately passed away at 41 years after cardiac surgery. Their paternal grandfather passed away at 35 years and the paternal uncle at 21. And if you have a look at the 4-generation pedigree which I've created for this family, you can see that going back to the paternal grandfather already dying at 35 from hypercholesterolemia, that we didn't have any information on whether he was treated or not treated at that stage. But then having two sons, both of whom are affected with hypercholesterolemia, and then the one, obviously the one son passed away before he had any children, and then the other one, who was part of our index family, passed away at the age of 41. So what has happened with this family is that, yes, we understood that there was a family risk of hypercholesterolemia, but what the genetic testing has shown is that there's an underlying genetic cause, that treatment is absolutely necessary and has already in fact started below the age of 10 in hoping to ameliorate the condition itself and prolong their life going forward. What's important to understand for these two boys, however, is that as they grow to reproductive age, that the risks for their children themselves would be around 50%. And so what we found by doing this genetic testing is that both of them had the same genetic fault in the LDLR, and it is this particular variant, although not common necessarily in South Africa, so it's not seen as what we would call a founder mutation, has been seen in many different countries across the world. So Korea, Italy, South America, Asia, Northern America, and it was initially seen in South Africa in 1993, and there have not been a lot of case studies published since then. So having a look back in the literature, there was quite a bit of work done on LDLR in the mid to sort of late 90s, and then nothing really much has been published until 2018, 2020, where the whole idea of looking at the genetics of hypercholesterolemia was revisited. And I just had to put up this comment because one of the papers that I looked at said that in 1997 they'd set up a database to set up the correlation between the genotype and the phenotype genotypes for familial hypercholesterolemia. And in the paper, it says we've set up a database on Excel, and you're welcome to contact us if anybody needs to get some more information. And so what has happened in the 15, 20 years since then is that we now have international databases that are readily available online. So this brings me to the next part of the topic, where we talk about pharmacogenomics. So if you remember at the beginning, we spoke about Mendelian inheritance. We spoke about identifying causative genes for specific genetic conditions. We've also now spoken a little bit about common disease risk, how to predict a risk, how to stratify people according to their risks, and how to identify patients and focus on early behavior change and risk reduction. So looking at pharmacogenomics is now looking at people's genetics, and I'll explain a little bit more about that now, in terms of what they should be looking out for, what they can do to intervene early, and how to ameliorate the onset of any potential common diseases that may occur because of family history. And so the advent of pharmacogenomics has also enabled us to look at particular enzymes and ways that drugs are metabolized to find out how effective they're going to be and what the dosage of certain drugs could be or should be, depending on what we find. So just to understand some of the words that are used in pharmacogenomics, and starting off with the definition. So pharmacogenomics is the study of the inherited genetic information that influences drug response and drug behavior. And so these are divided up into, and Dr. Janine did mention these words as well, pharmacokinetics. And pharmacokinetics is how the drug is absorbed, how it's distributed within the body, metabolized, and then excreted. Whereas pharmacodynamics is all about how the drug interacts with its target and what its mechanism of action is. And so since the pharmacogenomics knowledge database was started, there are more than 2,000 genes that have been added into this database that have an influence on how drugs are absorbed and metabolized, or how they interact with the target and what their action mechanism should be. And I love this little picture because as much as we always want to look into a crystal ball to see what lies ahead in the future, we can now do scientific testing to predict to some sort of level what we potentially up against. So when we have a look at pharmacogenomics, the important question to ask is what is actually tested? So yes, we're testing the DNA, but what we're actually testing are what we call SNPs, or single nucleotide polymorphisms. Now, polymorphism is just it's often a single polymorphism, so a single base pair that has changed. And the word polymorphism means just a different form of. So if I had to use a particular facial feature or something that someone is familiar with in terms of polymorphism, polymorphism does not mean that there's a change in the gene that causes disease itself. It's just a change within the gene that is a different form from each other. So if we look at people with different color eyes, we know that some people have got blue eyes, some people have got brown eyes, some people have got green eyes. And it's not that people with blue eyes can't see, or people with brown eyes can see better in the dark. There are just different color eyes. And so that is a physical feature that I would liken to the idea of what a polymorphism is. So when we talk about these SNPs and the changes that we find within these SNPs, we talk about sequence variants and not about mutations as such. So I know that I spoke previously about possibly trying to get a word away from the word of mutations because of the negative connotations. And this really fits in with this whole idea of that there can be changes within people's DNA and between different people in the same population, but it doesn't mean to say that these changes in the DNA are causative of a particular condition. However, sometimes when there are differences, they can be what we call actionable sequence variants, which means that it has been shown and proven that if a certain action is taken when someone has a particular variant, that it is useful and helpful going forward. And I'll explain what I mean by that. So having a look at a pharmacogenomics panel, we have a look at drug metabolism. So the phase 1 is looking at the cytochrome P450 enzymes. The drug metabolism part 2 is looking at the TPMT, the SLCO1B1, and the VCORC1 genes. The other genes that we look at that code for obviously for different variants are the ApoE gene, the COMT, the factor 2 and the factor 5, which Dr. Yining has spoken about, and then the AMTHFR, which has to do with vitamin B metabolism. So one of the factors that is related to ApoE and where it has been used previously is within families where people may or may not develop Alzheimer's. And so ApoE3 and ApoE2, which are the normal variants, and ApoE4. So when someone is homozygous, they didn't put ApoE2 on this particular slide, but having a look at ApoE4, when someone is homozygous for ApoE4E4, that is where the highest risk for Alzheimer's comes in. But the risks are only greater than the general population risk, and you can see the risks on the side on the y-axis are not that great. So why do we have a look at pharmacogenomics and how it can help us in terms of drug dosages and interactions? So if we could imagine a whole group of people, all who have been diagnosed with the same condition, there are different ways in which people can react to a certain drug at a certain dosage. So we could have some people who reap no benefit from being on that medication, and they have a lot of adverse drug reactions or toxicity. Or we can have a group of people who do benefit from the medication, but they also have a lot of side effects. There is also a group of people who do benefit from the drugs and don't have any side effects or adverse drug reactions at all. And then there are a group of people who have no benefit whatsoever, but also no toxicity from this drug. So how do we stratify or help people instead of this guessing and changing dosages and seeing how we feel and seeing how we react to certain medications? How can we stratify this to make it easier and quicker to come to the right medication at the right dosage? So this is one of the slides that we have on our Empath chat, and you can access that on our Empath webpage. But this is just a whole lot of the CYP enzymes and whether what happens in the actual gene is a deletion, a copy variant, or a duplication or multiplication of certain genes, and its effect on the messenger RNA and then on the enzyme as to whether there is no metabolism of the particular medication at all, or there's an increased metabolism of the drug. I'll show you what these mean in practicality in a second. So if we have a look at this is another case report where there's a particular patient, and what's important about the pharmacogenomics is that the particular conditions that the patient is affected with and the particular medication that the patient is on are important in order to make correlations between what is happening in terms of the metabolism of the drugs and then what their genetics is actually saying in terms of how well they metabolize and use these drugs. So this particular patient, if we have a look at ApoE, this person is not at an increased risk for Alzheimer's. If we have a look at the CYP1A2, they are a normal metabolizer. However, if we have a look at CYP-C19, they are a rapid metabolizer. And so the dosages of the medication that is given may have to be adjusted for this person. The CYP2C9 and the CYP2D6 are both, in fact, the 3A4 as well, are all intermediate metabolizers. So may or may not have to adjust the dosage. If we have a look at CYP3A5, though, this person is a poor metabolizer. And so we would have to have a look at what drugs are metabolized by this particular enzyme as to what effect that is going to have. This person has a normal risk of thrombosis, so general population risk, and a reduced MTHFR activity. Having a look at the SLCO1B1 as normal function, and the VCORC1 gene is an intermediate warfarin sensitivity. So going back to Dr. Yanin's talk. So one of the first things that the pharmacogenomics report does is that it gives us some ideas about risk management. So this is from the same report of this case study, where the person is the genetics of the person is not associated with type 3 hyperlipoproteinemia. Hyperhomocystinemia because of the risk of depression. In fact, this patient reported, the GP reported that the person is being treated for depression and is on a certain medication. So with having a look at the homocysteine pathway, there is no increased risk of hyperhomocystinemia. Thrombophilia said there was a normal risk, and then I've put this on twice, but this is also for the risk for thrombosis as well. So looking at the same genes. However, looking at the dosing guidance in terms of this patient, you can see on the right-hand side, we've either got information that relates to certain drugs that are actionable or they are informative. So in terms of depression for this person, if they were treated with citalopram, it possibly isn't the best medication that this person could be put on, and the GP should consider another medication where the enzymes are able to metabolize in a better way. So because of being a rapid metabolizer, either the medication itself or the dosage is going to have to be adjusted. Having a look, this person also has hypercholesterolemia. So having a look at the atorvastatin, where this person is an intermediate metabolizer, it's associated with a lower enzyme activity, and so the dosage may need to be adjusted for this person as well. At the end of the pharmacogenomics report, there is a patient information section where there is a summary of the particular genes that are tested, the patient's result, and then the activity of the enzyme or the gene and how it has an effect on the medication. So this is very handy for people to cut out, to possibly laminate, keep in their purse or in their wallet, so that when medications are prescribed for any particular condition, that either the GP or the pharmacist will be able to have a look at this genetic information and make decisions about the medication and about the dosages based on the genetic results. And so remember that because this is germline testing, this pharmacogenomic testing stays like this forever. So this is a worthwhile test in terms of being a lifelong and not changing throughout the life of any medication or any dosages or any new diagnoses. So what would the benefit to the patient be of having a pharmacogenomics test? So I know from experience in my family where someone has been put on a medication and then it doesn't really work, and then they change to another medication, and then the dosages are played around with. So in the long run, this will save money for the patient. It could also have the potential to prevent unpleasant or fatal side effects. It improves the efficacy of the treatment plan and overall would improve the quality of their lives without having to mess around with different dosages and different medications and approvals. It also leads to a reduction in healthcare costs. So we would be able to decrease the adverse drug reactions. There would be a decrease in failed clinical drug trials for people who are entering into the clinical drug trials and have their pharmacogenomics tested before entering into that drug trial. There could be a decreased time required for the drug approval from the clinical trials, decreased time for a patient to be on a certain medication, a decrease in the trial and error approach for effective medication, and a decrease in effects of the disease by early detection. So all of these benefits go along with pharmacogenomic testing and having this information up front, being armed with this knowledge to make informed decisions regarding healthcare going forward. So that was just a brief overview of the pharmacogenomics and the benefit of having that testing done. So let's go back to our timeline of what we had a look at through the first session, where we had a look at the fetus, planning of a baby, non-invasive prenatal testing. Then we moved on to childhood and had a look at childhood conditions. Now we've had a look at the intermediate phase between disease prevention from 10 to 20 up to the age of around 60 years. So we haven't touched on cancer yet. We're going to touch on that next week. But as you can see, at the age of 60, we have a molecular diagnosis of certain conditions, and we have the pharmacogenomics platform, which can help. And so you can see that that lifespan during adulthood, there's good 40 years where there are certain diagnoses that can be made from a genetics point of view, and then obviously the pharmacogenomics, which helps with treatment of any of those conditions. Okay, so that brings us to the end of today.
Yes, thank you everyone, and thank you for joining us this evening. Please do remember to join us next week again for our last session, and thank you very much.